eu sou Sergio do grupo Oncoclínicas Brasil. Estou conversando hoje com a doutora Partridge, que é oncologista clínica do grupo de mama do Dana-Farber, em Boston, Estados Unidos. Nós vamos falar sobre o câncer de mama em mulheres jovens. Dr. Partridge, is breast cancer different in young women?
Yes and no. Some parts are different in that young women are more likely to get more aggressive breast cancer, and they're more likely to have bigger tumors and more lymph nodes involved, so more advanced disease when they're diagnosed. But otherwise, it's not so clear that the disease itself is different in young women, although we do treat it a little bit differently in young women, especially because of their hormonal status. They're more likely to be very premenopausal.
And what are the considerations that you have to make when you choose hormonal therapy for these patients?
So when we think about how to treat a young woman with hormone-sensitive breast cancer, we need to think about her menopausal status, and most of the young women will be premenopausal. And if they're very young and they have more than a little bit of cancer, a more advanced cancer especially, then not only will we want them to take pills like tamoxifen or an aromatase inhibitor, but we'll want to suppress their ovaries because that's been shown to add substantially in terms of prevention of future breast cancer events. That's kind of the biggest issue.
How do you choose patients that will have ovarian suppression versus tamoxifen alone?
So the way that I choose who needs ovarian suppression and who doesn't is really based on the risk of the cancer. There is the age cutoff that was done in the SOFT analysis where they looked at 35 and under, but if a 31-year-old has a very small cancer, I often will do tamoxifen only because that woman probably wasn't going to get chemotherapy. She wasn't high enough risk to warrant a super aggressive approach. And I'd leave it up to the woman in some ways. I talk to her about the data and we decide most women don't want more treatment, although some do. And many tolerate it beautifully, although some have difficulty with side effects. So I think the most important thing for the young women when we start them on endocrine therapy is to make sure they understand that yes, we're going to try this, and yes, the standard is 5 to 10 years, depending on the regimen, but that it's a conversation. And if they're having a very difficult time with any one of the treatments or any particular symptom, they need to communicate with us so we can help to support them and sometimes even make a different decision. So yes, ovarian suppression with an aromatase inhibitor may be kind of the best we got for very aggressive disease, but if a woman isn't tolerating it and she stops taking it, I'd rather give her tamoxifen than nothing.
So it's a choice that you make with the patient, right? You have to talk to the patient and explain side effects and what she's going to feel. How do you treat the symptoms of ovarian suppression and aromatase inhibitors?
So the most effective treatments for the hormonal symptoms of aromatase inhibitors and ovarian suppression are typically things like venlafaxine or Neurontin, both of which have been tested to help with hot flashes. Another new player on the stage is oxybutynin, which was recently shown to help with hot flashes in survivors. And then we also address the very problematic and frequent issue of vaginal dryness that can happen with suppression of the estrogen. And usually we use non-hormonal lubrication recommendations, and that can work really well, but you want to be proactive. You want to tell women about it so it's not a surprise, so that they're ready, so that they stay sexually active and don't let it become a problem.
Is libido a problem for these women?
So in some studies, yes, and that's multifactorial, right? It's not necessarily the meds. For some it is, but for some it's the whole process of the breast cancer, the stress, the fatigue, the relationship issues, the body image issues. So we try and approach the sexual dysfunction from a multifactorial view and try and pick apart the different things and help them with each of the problems, and you can get them to a better place.
And what about babies for these women? Many of them have no children yet or want more children after breast cancer. Is that safe?
So that's a great question. And the bottom line is that the data we have available suggests that women do just as well having a baby after breast cancer as women who don't have a baby after breast cancer. Meaning from their breast cancer standpoint, you're no more likely to hear from your breast cancer if you have a pregnancy afterwards. That being said, the data available to inform that has limitations because we've never been able to do, nor will we be able to do a randomized trial the way we like to do to test strategies. And so what we do now is counsel each woman based on her own risk and her preferences. And we're also studying it in a large international trial called the Positive trial, So someday we'll have some information about taking a break from endocrine therapy, allowing women to get pregnant and then get back on and see if they do just as well as women who take it straight through.
What if the woman is of high risk and she still wants to have a baby, despite being at very high risk of recurrence, many lymph nodes, and she wants to stop the hormone treatment for pregnancy?
Yeah. So that's always a difficult one, I think, both for the patients and her loved ones and for the providers. I think we have to be honest with our patients and tell them that the data tell us that having a baby doesn't increase their risk, but someone who's very high risk might have a chance of having a recurrence while pregnant, or with a newborn at home, or in the years shortly thereafter. And so what I typically try to do is support that person to take their endocrine therapy for as long as they are willing. And then if they come off, I want to get them back on. So we'll negotiate kind of, okay, how much do you want a baby? Is there any other way for you to get a baby? If not, in the very high risk situation, I will support them because they're going to do it anyway. And I don't want my patient feeling like they're a criminal because they want something that many young women want. There's nothing wrong with the desire, and they make the decisions anyway with their loved ones. And we try and be supportive with the reality check of, you could run a serious risk here, and that's a really big problem if you get recurrent disease. And women, I find, make their own decisions and make, I think, pretty reasonable decisions most of the time when they're armed with the information.
Now, in Brazil, the median age of breast cancer is much lower than in the US. It's about 53 years. And about 45% of our patients are below age 50.
Wow.
Do you see an increase of breast cancer in young women in the US also?
So I used to say no to that question. And very recently, we've seen a slight increase in our prevalence of young breast cancer patients. There are more young women for sure getting breast cancer, but our population of young women has also increased. But the rates are also going up a little bit now. And that may be true here as well. And it probably has a lot to do with our environment. Some of the same things that predict increased risk of breast cancer in older women, like physical activity or lack thereof, weight gain, when they have their babies, also increase the risk of premenopausal breast cancer.
Thank you very much.
You're welcome.